I spoke earlier about systemic symptoms. We're going to go to the exact opposite, and we're going to be discussing local symptoms for patients with head and neck cancer. Head and neck cancer is my favorite topic, and it's the patient base off of which I do most of my work. There are so many side effects that affect the head and neck cancer patient population. I had to choose, and I chose two specific areas to discuss today. We're going to be talking about the soft tissue complications, and then once I finish discussing the soft tissue complications, I'll be talking about the oral complications of head and neck cancer therapy. No disclosures for this work. So what we're going to start with is talking about lymphedema and fibrosis. As all of you are probably aware, the head and neck has a massive lymph node, or a massive number of lymph nodes within the anatomic structures of the head and neck itself, 300 lymph nodes. This is a third of the total body content of lymph nodes. Lymph movement requires contractions of segments between valves, and that can be aided by external compression of the lymphatic structures by movement, muscle contraction, arterial pulsation. Lymphedema occurs when you have accumulation of lymphatic fluid and proteins in the interstitial spaces, and that happens when the capacity for lymph drainage is overwhelmed by lymph delivery. There are a number of circumstances within the head and neck patient population where that happens. One is when patients undergo surgery, so they have removal of lymph nodes and transection of lymph channels. And in the postoperative setting, you also get decreased movement and decreased muscular contraction, which diminishes lymph flow. Similarly, radiation causes fibrosis of lymph nodes, and it causes scarring of lymph channels, and again it also causes decreased mobility and contractility in the muscles of the neck. So both of our cardinal treatment techniques, which are our curative treatment techniques in the head and neck patient population, result in significant damage to the lymphatic structures. Quite honestly, as my surgeon says, well, my goal is to destroy the lymphatic structures. The second process, which is fibrosis, and we all intuitively understand fibrosis better than we understand lymphedema, but fibrosis is the accumulation of collagen and other extracellular matrix components in such a way that there is a perturbation to the normal balance of synthesis and degradation. So we get more synthesis and deposition than degradation. And this, of course, can lead to a woody texture to the tissue. So there's an altered texture. And in conjunction with that, although it's not a one-to-one relationship, the tendency is when the tissues become woody in texture or hard, they become less compliant, and you get loss of range of motion and functionality. So here's a conceptual framework which is applicable to the head and neck patient population, where treatment, which is surgery and radiation with or without chemotherapy, and or tumor cause tissue damage. We heal, and we can have a normal repair process where we go basically back towards a normal functional status. But more often than not, what will happen is we get soft tissue damage that results in some degree of lymphedema and or fibrosis. And these two processes can occur simultaneously. I think one of the most important things to recognize is that lymphedema leads to, end-stage lymphedema is fibrosis. So if you have somebody who has lymphedema, if that lymphedema is not treated, what happens is an inflammatory process, a local inflammatory process ensues. And then that results in the deposition of fibroadiposity or fatty scar tissue. Lymphedema in some ways reflects and is thought potentially to be akin to a local obesity process. And so when you think of the patient who has chronic lymphedema, think of fibrofatty scar tissue, and that's what you're dealing with. So lymphedema over time will progress to a fibrotic process. Both lymphedema and fibrosis are associated with chronic inflammation. So both of these processes can worsen over time. And we're not talking about, oh, it's going to stop after a couple of months. We're talking about people who, or patients who will have years after their surgery or their radiation will develop significant progression of their lymphedema and fibrosis. So it is a chronic problem that they have to deal with for the rest of their lives. Now, I think we've all seen external lymphedema. It commonly occurs in the submental region, but it can include any part of the face and neck. It is manifested predominantly by swelling. This is a scoring system that we've developed at Vanderbilt. We've done a lot of work on lymphedema in the head and neck patient population, and we've broken down lymphedema into and fibrosis into several types. A would be where there's just thickening of the skin, which would be a kind of an early phase. B is when you have soft tissue swelling, and that soft tissue, the swelling feels as though the tissues are fluid filled, kind of like a balloon. As the lymphedema progresses and you get scarring and you get fibrofatty scar tissue deposition, what happens is you go to C. And C is the very firm, non-reducible soft tissue swelling that is permanent. D would be fibrosis without swelling, which you will see sometimes in the surgical patient population. Now, in addition to the external lymphedema that we all think about occurring in the soft tissues of the submental region, the cheeks and the neck, you can also have internal lymphedema. So that would be involving all of the structures that are important for swallowing, for speech. You can get lymphedema involving the sinuses, so that sinus drainage becomes challenging. There is a system for grading internal lymphedema, and that is the Patterson Scale. And the Patterson Scale is graded during endoscopic evaluation, and there are a number of sites and a number of spaces that are evaluated, and you will grade as none, mild, moderate, or severe tissue swelling. Now, seminal work done by one of my colleagues, Dr. Jia Dang, when she was a doctoral student, demonstrated that in a population of head and neck cancer patients at least 3 months out from completion of therapy, that the rate of internal lymphedema at that lymphedema at that one visit was 81%. Excuse me, not 81%, it was, I have to go back and add it. Only 32% did not have internal lymphedema, so it was close to 70%. So we know internal lymphedema is extremely frequent, as is external lymphedema, but there have been no good studies that really describe the progression of lymphedema and fibrosis over time in the head and neck patient population. So we conducted an R01, which was a 5-year study, recruiting patients from the time of diagnosis and doing periodic evaluations for a 1.5 years post-treatment. And we used the best available techniques to identify both lymphedema and fibrosis. What we found was that at the end of treatment, 71.6% of patients had developed late effect external lymphedema, 93% had developed internal lymphedema, 83% had one or the other, had both, and then 100% of patients at some point in time had lymphedema and or fibrosis. So 100% of patients at some point in time had either lymphedema or fibrosis. Now, what we then did was we wanted to look at the trajectory across time. And we broke the lymphedema and fibrosis down into those who had none or mild at any given time point versus those that had moderate to severe. So we wanted to see just how does this progress. And what we have here are 3 different slides. We have internal and external lymphedema, with the blue line representing those with mild to moderate findings, and the red line those that had, none to mild, and this is moderate to severe, for internal and external lymphedema, and then fibrosis. What you can, and these are the time points are on the x-axis. What you can see is that lymphedema and fibrosis increased over time, peaking between 6 and 12 months post-treatment, and then diminishing, but not going back to baseline levels. You can see that the curve for fibrosis was shifted to the right, as one would expect. So fibrosis peaked later, as one would expect, and then you did see some decrement in the findings with regards to fibrosis, but again, not returning to baseline. So the results from this study were astounding. 100% of patients, 100% of patients had lymphedema and or fibrosis at some point across the trajectory. For the majority of patients, it was moderate to severe, and although it did improve over time, it never returned to baseline. Okay, so now we know that lymphedema and fibrosis are important problems. What are the effects of lymphedema and fibrosis? Why should we care? Well, one of the reasons why we should care is that when you have lymphedema and or fibrosis affecting the tissues, the tissue function is altered. And when you alter the tissue functioning because of these soft tissue complications, you have symptom burden that can be persistent forever. Right? So soft tissue changes alter function, which results in symptom burden. And so this is a new way of kind of thinking about the late effects of head and neck cancer therapy. Because instead of thinking of isolated symptoms, we can hearken back to the underlying cause. So we're going to pick one that we're going to look at, one symptom we're going to look at in detail. And that's one of the most important soft tissue complications for head and neck cancer patients, which is dysphasia. So, and when you conceptualize it, you think, yeah, dysphagia is a soft tissue complication of surgery and radiation. With the original study that we had done, I've got to keep my studies straight in my mind. This was the original study that was done. This was a cross-sectional analysis and looking at swallowing and the correlation between external lymphedema, internal lymphedema, and combined. Combined lymphedema means both internal and external. And what you can see is a very strong correlation between the presence of lymphedema and swallow dysfunction. So in the R01, we went back and we looked at 81 patients who had had swallow studies done at various time points across their trajectory. And those 81 patients also had self-report measures. So we took a self-report measure. We had a physical assessment of external lymphedema, an endoscopic assessment of internal lymphedema, and a modified barium swallow. And what we wanted to find out was what is the degree to which physical findings, patient report findings, and modified barium swallows correlate. And what we found was that there was, and this is the Patterson Scale, so endoscopic evaluation, these are the sites, and each one of these sites was analyzed separately, so we're talking about a single site. So any grade abnormality with regards to lymphedema at that single site was correlated with self-report on 3 different subscales from the Vanderbilt Head and Neck Symptom Survey: swallow solids, swallow liquids, and nutrition. We weren't really very hopeful that this was going to be a positive analysis, because you could sit there and say, well, one site, you know, if you have a swelling at one site, yeah, it can't be that powerful an effect that we should see a correlation with self-reported swallow dysfunction. We were shocked, because all of the green were the positive correlations. So swelling on the Patterson scale for each of these individual sites correlated with patient-reported complaints of swallow dysfunction with swallow solids, swallowed liquids, and nutrition. That was shocking to us. This is looking at the modified barium swallows, and they were measured using 2 different techniques, the NOMS and the DOS, and I'm sure you all are familiar with the NOMS, because that's what all of the swallow therapists use to report the grade of dysphagia in patients who undergo swallow studies now. So let's just look at the NOMS, because I think it functions better than the DOS. It doesn't matter. Every single solitary one of these parameters was positive. That means when we scoped the patient, if they had any degree of lymphedema at that site, when we looked to see if there was a correlation with the findings on the modified barium swallow, the findings were positive. Again, that's overwhelming. So pictorially, we also looked at scans, CT scans. Could we look at CT scans and look at tissue swelling on CT scans and correlate that with function? So this is, and this comes from a study that is ongoing, but I'm going to give you an exemplar. This is a pre-treatment patient, and we developed a method for assessing scans so that we could actually measure this. Look at this patient post-treatment. Pre-treatment, nice thin epiglottis. If you look at the prevertebral soft tissue, very thin. Look post-treatment. You see how thickened the epiglottis is? And you see how thickened the prevertebral soft tissue is? You can imagine that that patient is going to have difficulty swallowing. Our radiologists now always give us a report on this. This is just another closer view, baseline versus 4 months post-treatment. You can also look at and grade the fat and fat stranding, baseline and post-treatment. Same thing, baseline and post-treatment. So what does this look like over time? Are the changes that we see as measured on scans similar to the patient self-report and similar to our findings endoscopically and on external evaluation? And the answer is yes. So this is looking at prevertebral thickening on a series of 156 scans over time. And what you can see is that baseline and immediately post-treatment, no significant prevertebral thickening, but as the lymphedema worsens, you get an increase in vertebral thickening over time. It does get better, but never returns to baseline, and a significant percentage of patients have long-term abnormalities in the soft tissues in the prevertebral space, which is, of course, where many of the muscles of deglutition are placed. Same thing for epiglottic thickness. And you know what I find, so once you're out a year, 18 months, this is not acute edema that's going to get better with steroids, right? This is now chronic change. And hypothetically, we would expect that to be fibrofatty scar tissue. So what are the findings and the implications of that work? First of all, we know that lymphedema and fibrosis are present to some degree at some point in all patients. For most patients, the level was moderate to high in severity. It does improve over time, but it remains problematic for a high percentage of patients, and it's associated with substantial symptom burden. With regards to lymphedema and the symptom that we chose to spend most of our time talking about, which is dysphagia, there are a couple of questions that come up. And I think they're really important questions for us to think about, because at what point across the trajectory of treatment and recovery do we no longer have acute edema, and we now have lymphedema, and then when does it become fibrosis, so that we know when therapeutic interventions directed at acute edema and lymphedema, because you can treat acute lymphedema, right? Those are treatable phenomenon. But once you hit fibrosis, it's much harder to treat. So when are you transitioning through these different phases from acute edema to lymphedema to chronic fibrosis? And I think it also begs, I don't know if you have read the literature on swallow therapy, but one of the big things in swallow therapy has been maintenance of swallow effort throughout the entire trajectory of treatment and recovery. Right? So you need to swallow and swallow and swallow and swallow. Well, you know, when you make a swallow attempt, what you're doing is you're contracting those tissues, which is helping lymph flow. So it may be that swallow in and of itself is a therapeutic intervention for lymphedema in those tissues, and ergo pushing the swallow and the swallow and the swallow may be in some way diminishing the local lymphedema and long-term diminishing the amount of fibrosis. Now, I want to talk about two very specific fibrotic syndromes that everybody needs to know about. One is Trismus. We know that radiation and surgery can both result in Trismus. The sequelae of Trismus are profound. Other than the fact that it's uncomfortable for the patient, they get joint sounds, there's pain. The biggest issue is the restriction in movement, which makes it difficult for them to eat. It impairs their speaking. It limits their dental care interventions, makes it difficult for them to intubate, and it reduces pulmonary function. We know that when we're treating patients with primary radiation therapy, there is a strong correlation between the radiation dose to the muscles of mastication and the development of trismus. And with this epidemic of oropharyngeal tumors, many of which are being treated with radiation, we're seeing an epidemic of trismus. It is felt to be a fibrotic process. There's a very steep dose response curve. The trajectory is such that it actually can be present at the time of diagnosis due to tumor. It worsens during radiation therapy and can worsen for months afterwards. Concurrent chemo may make it more frequent, and it's unclear right now whether IMRT actually alters the incidence. When we look at the incidence of trismus, and this is in a post-operative patient population, and trismus defined as less than 35 millimeters, you can see that in the fully dentate patient, the percent is 31%, the partially edentate 40%, and the edentulous patient 57%. What we know is that if trismus gets to the point where the interincisorial distance is less than 25 millimeters, patients can't even choose soft solids. They can't even choose soft solids. So it's incredibly important that we identify trismus early and intervene. And one of the things that I think is really important to recognize is once you have very severe trismus, it is hard to treat. You can, with a very dedicated patient, they can work to reverse trismus, but it's hard. There have been a number of trials looking at the use of techniques or these jaw stretching devices like the Therabite or the Dynasplint to see if we can prevent the development of trismus, and the answer is no. These techniques do not help prevent trismus. Routine jaw stretching does just as well as these jaw stretching devices. However, once trismus is present, jaw stretching devices can help significantly. The second fibrotic process that we have to be very aware of is proximal esophageal strictures. Again, this is a problem in patients who receive radiation therapy. It's usually seen with doses above 6,000. It appears to be increased in frequency when we add concurrent chemotherapy. And why is it important to recognize this? You have a patient who's 3 to 6 months out from therapy and they're having trouble swallowing. Let's make sure that it's not due to a stricture, which can be easily addressed by endoscopic dilatation procedures. Endoscopic dilatation of esophageal strictures are highly effective in improving swallow function. From a technical standpoint, success rates are 80% and above. From the standpoint of patients' sense that their dysphagia has been relieved or at least improved, it's even higher than that. Now, the thing to recognize is oftentimes these patients need multiple repeated dilatations in order to alleviate their symptoms, or their symptoms may recur and they may need periodic dilatation procedures, but this can be incredibly important for patients to be able to eat normally. All right, so that's the discussion on soft tissue abnormalities. I chose that topic because I really think it's a topic that is not discussed often enough. Let's move on to a second topic that I don't think is discussed often enough, and that is the oral complication, or the oral complications of therapy. We're going to begin with teeth. We all know that the enamel is composed of calcium and phosphate crystals, or hydroxyapatite crystals, and these are predominantly derived from saliva. We know that fluoride, which is in our toothpaste and our water, helps drive the process of mineralization of the enamel. So the enamel, like the bone, is constantly demineralizing and remineralizing. And there are factors that push to demineralization, and there are factors that push to remineralization. You have to have calcium and phosphate to remineralize, and fluoride will push in the direction of remineralization. So, so saliva is absolutely integral to dental health because it provides the substrates for enamel. It also maintains oral pH. When pH drops, at that point in time, enamel can demineralize or is pushed to demineralization. It also acts as an antibacterial, and we know that there are some bacteria that are cariogenic. When we radiate head and neck cancer patients, we all know that one of the problematic acute and long-term effects is hyposalivation and xerostomia. These are two different phenomena. Xerostomia is the complaint of dry mouth. Hyposalivation is actually having decreased saliva. Salivary flow drops dramatically and quickly as soon as as soon as the salivary glands are radiated. And recovery is slow, and it may be partial or non-existent depending on the dose of radiation to the salivary glands. I want you to, I don't know if you are familiar with the Stefan curve, but this is a curve that you really need to be familiar with. What we have here is a depiction of the oral pH, and 7 is neutral. When you eat, the pH in your mouth drops, and at somewhere around 5 or 5.5, if you go below that, that's the zone in which your teeth are prone to demineralize. So this is what happens when you eat. Your mouth has a nice pH, you eat breakfast, it drops down, the pH drops. The normal saliva carries away the debris, brings your pH back up. You go through the morning, you have lunch, You have a snack, then you have dinner, and every time you eat, your pH drops. But your saliva brings it back on up because it buffers. This is the Stefan curve for a patient who is xerostomic, or excuse me, has hyposalivation, compared to the curve for a normal patient. As you can see, if you don't have saliva, the pH goes down and it doesn't come back up. So unfortunately, that means that your teeth are exposed to acid on a constant basis. This is why it's very important for head and neck cancer patients to brush after they eat. Either that or swish with their baking soda and saltwater gargles. It's also important to know that there are foods that are cariogenic, foods that are karyostatic, and foods that can actually help prevent caries from developing. And as one would expect, the anti-cariogenic foods are those that have include milk products such as cheeses because of calcium, right? There are buku pictures similar to this where you can, we hand one of these out to our patients every time they start radiation to let them know what are the foods that are acid and what are the foods that are not. It helps them understand what they're eating and its dental impact. Why do we care about this at all? It's because radiation dental caries are a profound problem in this patient population. Radiation caries can develop quickly, within 2 to 3 months of completing radiation. They progress very rapidly, very rapidly. Once they develop, it's very hard to reverse radiation caries. The clinical manifestation are increased translucency of the enamel, change in coloration, friability with fracture, and amputation of the teeth at the gum line, which looks something like this. So you get the fractures, you'll get dental loss. Dental loss, of course, leads to altered intake, and altered intake, as we know in the elderly patient population who have a higher rate of being edentulous, leads to dietary inadequacies. So our patients who are xerostomach or who are hyposalivation are at high risk for dental caries and must be treated accordingly, which means that you need to make sure that they are using their fluoride, that they're brushing, they're flossing, and many dentists will also use antibacterial like chlorhexidine and calcium phosphate supplements to coat the teeth to try and improve remineralization. Okay, next, mucosal sensitivity. One of the late oral effects that most people are unfamiliar with. Mucosal sensitivity is patients, you'll hear patients say, my mouth burns. Okay, it's a peripheral neuropathic pain. It is the result of peripheral sensitization by peripheral cytokines associated with mucositis. So the tendency is that people who have the worst mucositis have the worst long-term mucosal sensitivity. It can be, some patients will say, well, my mouth doesn't burn all the time, but if I eat spiced foods, acidic foods, hot foods, my mouth will burn. So it changes patients' food preferences. And there, as I said, the mechanisms are upregulation of sodium channels and sensitization of peripheral nerves. Mucosal sensitivity can be permanent. It does not respond well to opioids. Our tendency is to use topical lidocaine containing mouth rinses or ketamine. Ketamine works well because it's an NMDA inhibitor, so we have a topical ketamine that we use. And you know, you'll sit there and say, well, how often does this happen? Ask your patients about this because it's amazing how frequent it is. These are questions from the Vanderbilt Head and Neck Symptom Survey. This is greater than equal to 1, which would be all grade toxicity, greater than equal to 4, which is moderate to severe toxicity. And these are all long-term patients. So these are patients who have completed therapy at least 6 months prior to filling out the questionnaire. And you can see 80% of patients said they had sensitivity to hot, spicy, or acid food. For 56% of the 58%, it was moderate to severe. It changed food intake in a very high percentage of patients. So it really does have a profound effect. And it's one of the toxicities that I think people are less familiar with. Another toxicity that I think, oral toxicity, that tends to be underplayed is taste alteration. And we all know that patients with head and neck cancer have alterations in taste. We know that. But I think what we don't recognize is how impactful it is. Taste is based on a variety of factors, which will include taste, the texture of the food itself, the temperature of the food, but also smell. And there are 5 basic qualities to taste: sweet, bitter, salty, sour, and umami, which is that savory flavor. And that is where most of our pleasure from food is derived. And it has the strongest correlation with quality of life. When patients have decreased taste, they have decreased interest in food. It's hard to get them to eat. They will alter their diet in such a way that which is maladaptive, right? It's a maladaptive change because they'll limit what they eat, and that limiting what they eat leads to dietary deficiencies, and it can also lead to weight loss, and of course, impaired quality of life. One of the problems is we'll tell patients, oh, you'll have taste changes for a little while, but then it's going to get better. But the reality is that is actually not the case. If you look at taste changes over time, yes, once you finish radiation therapy, at the end of radiation, and these are box plots, so if you can see, the median is extraordinarily high. Almost 80%, the median is at almost 8 on this scale of 0 to 10, with 10 being worst possible taste changes or absence in taste. So you can see that at the end of treatment, a high percentage of patients are affected. Okay, that's our clinical experience. But then if you look over time, what you see is that the median does drop, but a huge percentage of patients still have significant taste change, with a quarter of the patients having moderate to severe taste changes long term. We don't tell patients this. So we have to be very careful what we promise when it comes to taste alterations, because I think we oversell the fact that taste will return. Next is thick secretions, another problem that we way underrepresent with regards to the impact. When we look at thick mucus, and again, this is looking at late. This is looking at people 6 months or out from their treatment. This is not patients during treatment. You will see that 82% of patients will have some degree of thick mucus or phlegm. It's moderate to severe in almost half of the patients. Choking and gagging, or thick phlegm causing difficulty with swallowing, occurs in a quarter of patients to a level that is considered moderate or severe. So this is a much, much, much greater problem than has been documented, or it hasn't been documented in the past, which I think is the problem, but it certainly is much more of a problem than we let patients believe. And so I think one of the things that we have to make sure that we do when we are educating patients as they're getting ready to go through chemoradiation is we have to, these are considered, so many people consider these minor nuisance symptoms for the head and neck patient population. what is evident is A, they're neither minor, nor are they simply a nuisance. They do actually impact tremendously on long-term toxicity burden and quality of life. And what's even more important is we have to make sure we don't tell patients, oh, this will go away and you will be fine in 3 to 6 months. A significant percentage of patients will have persistent problems with their oral toxicities, and they'll have to maintain good oral hygiene for the rest of their lives in order to minimize the dental effect of hyposalivation. So I'm going to end there. Thank you.